Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I'm your host, Dr. John Hausman. Osteoporosis is one of those diagnoses that can feel deceptively simple. A DEXA scan, a T-score, a threshold. But in today's episode, Dr. Bobo Tanner argues that the T-score measurement itself is surprisingly easy to get wrong. He'll show us how to read a DEXA scan like a detective to improve the accuracy of the diagnosis of osteoporosis in your patients. Then, once you've decided your patient has osteoporosis, how do you choose between anabolic agents, denosumab, and bisphosphonates? We'll discuss how to risk stratify your patients with osteoporosis, as well as choosing treatments in light of your patient's comorbidities. Finally, we'll talk about the importance of sequencing osteoporosis medications correctly and why starting with an anabolic agent now can be much better than saving it for the future. Dr. Bobo Tanner is an assistant professor of medicine at Vanderbilt University in the divisions of rheumatology and allergy immunology, and he's the founder and director of the Vanderbilt Osteoporosis Clinic. He trained at Harvard University, Wake Forest University School of Medicine, and then completed an internal medicine residency at Vanderbilt. He pursued fellowship training with board certification in both rheumatology and allergy immunology. Dr. Tanner is past president and board member of the International Society for Clinical Densitometry, where he teaches the Quality Bone Density course and helps to develop guidelines for DEXA use and reporting. He's been recognized with multiple awards for clinical and educational leadership in osteoporosis care, and he truly is a master in this field. Enjoy. Bobo, welcome to the show.
Thank you, John. It's nice to see you and talk to you today about this.
Yeah. So osteoporosis, I believe that's one of your favorite topics. It's certainly something that we encounter quite frequently in rheumatology clinic. And I always struggle, is this something that I should address? Should I send them over to the endocrinologists? At least in our hospital, we have a thing, if you want to refer to a patient to rheumatology, because of osteoporosis, you actually get rerouted to the endocrine and bone health division, which is staffed by people like Dr. Marcy Bolster, who's a rheumatologist. But, in general, at least our practice, if somebody at hospital needs osteoporosis care, they're sort of referred over to that practice. I wonder if that's the same everywhere or what your take on the role of the rheumatologist in managing osteoporosis is.
Well, the American College of Rheumatology sort of set the standard for us almost 30 years ago when they started promulgating the ACR guidelines for steroid-induced osteoporosis. They sort of made us own that. And nobody else has done that, and nobody else has updated it. And the endocrinologists do a pretty good job with their regular updates of postmenopausal osteoporosis. And so we, as rheumatologists, have really come to own that territory. We do use a lot of steroids. That's how most of us got into that field. And so it's nice to have guidelines from our own organization to use, and they continue to get more and more refined. So I think we do sort of own this concept. Like your institution, endocrine is a choice, but unlike your institution, you have also a choice of sending to osteoporosis and rheumatology clinic. And at this point, that's really all my clinic does is osteoporosis.
Within the rheumatology division?
Within the rheumatology division. In other words, it started out with a little half-day clinic years and years ago, but as more drugs and more complications and more fear of how to use these drugs came in, it got busier and busier and busier. I'll tell you, the biggest addition to our demand to be seen is this idea of optimizing bone before surgery. The orthopedic surgeons in their literature have understood, particularly the spine surgeons, that if they can get bone optimized before surgery, their outcomes are going to be better as well. So that's been a big driver as well.
Oh, that's interesting. We'll have to talk about that. I wonder if you have a sense, sort of out in the community, if rheumatologists are behaving sort of the primary managers of osteoporosis in the general setting, or I guess a lot of that maybe is done by PCPs,
Yes, and I think what happens is when the PCP hits a threshold, the patient gets a side effect from one of the medicine, or the patient starts asking a lot of questions about potential side effects, that's when they sort of throw up the hands and say, hey, I need some help. And you're right. There are options in the community, either endocrine or rheum. And sometimes it's even the gynecologists who do a lot of postmenopausal care. And sometimes you see retired or non-surgical orthopedists who've taken an interest as well. So the nice thing about this field is it's shared by many, many specialists. And when you go to the big meetings, you see that. You see all these different specialists. But various rheumatologists let the world know that they are interested or they are not. But I think digging in the back of their brains are somewhat the reminder that the ACR has put out guidelines for what we should do with osteoporosis, certainly in the steroid world. So it does drive a lot of them to feel at least guilty that they should know, but they may not want that as part of their practice.
Got it. So at least sort of being knowledgeable in managing patients with rheumatic disease or patients with chronic steroids who have osteoporosis, or thinking about preventing osteoporosis in those patients should definitely be a priority. And then for some providers, some rheumatologists that like osteoporosis, they maybe also be able to sort of apply their skills to the general patients who may not have rheumatic diseases or
I'll tell you something interesting about bone density equipment. You might know this, but back in the day when it was reasonably financially stable to own a bone density equipment, rheumatologists were the number one specialist to own this. When you talk to the manufacturers, they bought more of these machines than any other, more than endocrine actually, because of that. Then, as you remember, sort of in the mid 2000s, it became sort of underwater to own a machine. The reimbursement became so poor that it really was hard to justify it. People couldn't even pay the maintenance on the machines anymore. So that kind of dropped away. And most of the DEXA equipment now is either in a hospital or an imaging center and not so much in practices anymore. But back in the day when this was really coming into its own, rheumatologists were huge in this field.
Super interesting. So we're going to talk a lot about osteoporosis. I was wondering if we could start by bringing out the major misconceptions that, clinicians have about osteoporosis and especially evaluating osteoporosis risk.
I think it's both a good thing and a bad thing. People have gotten very attached to the concept of a T-score. And as practices are busy and we think about little red flags and triggers, everybody wants to zero in on a T-score. Just show me the T-score and I can tell you whether or not I should write a prescription. That's a shortcut that is probably the biggest problem. T-scores are not always reflective of someone's fracture risk. They can be misleading in other ways. I would say about 40% of DEXA scans have significant reading errors in them.
Wow.
Yeah, no, it's huge. And so for the people who just look at the report and not at the image, you're really doing your patients a disservice. And particularly if your only goal is to find a T-score that kind of suits what you're thinking, then you're probably making a mistake. And I think that's where the problem is. It's good to remember that osteoporosis is not just a T-score of minus 2.5 or worse. People have had fractures at normal T-scores that deserve treatment, and people have pretty bad T-scores that are not due to osteoporosis. Osteomalacia comes into mind, for example. And so this total reliance on a T-score as the inflection point to make a decision, I think is where we go wrong sometimes.
So tell me more about some of those errors in reading imaging, because I don't think I could look at whatever images they have and make an assessment.
I bet you could. I think if you put an image of a spine up there and you would look and see if the edge detection was in the right place, and you would see it swooping out, incorporating a big osteophyte, you would start to wonder, now wait a minute, why are we counting an osteophyte as bone? And as the older you get, the more often you have degenerative disc disease, degenerative facet joints, and those degenerative changes incorporate osteophytes, calcium deposits, and they get counted as bone. And so somebody's going to say, well, your spine was perfectly normal. I don't know why we need to worry. But largely, there are vertebral bodies that should be excluded in the analysis because of these. Now, there are other artifacts that you might easily see that are kind of fun to see. There'll be surgical clips, for example, or aortic calcification that sits in front of the lumbar spine that would falsely elevate it. Unfortunately, for a screening test, you like to have a test that casts a wide net and captures maybe more than it should. DEXA is just the opposite. It's fairly specific, but it's not very sensitive. And so with these artifacts, they tend to falsely reassure you that somebody has a normal bone density rather than alert you that you ought to look further for something else. And so the problem is just the opposite of what you want in a screening test. You get artifacts that say, the T-score was normal and why go any further? And so you would be surprised about that. Now, there'll be subtleties with the hips maybe you wouldn't appreciate. The patients will tell you that the tech told them to internally rotate their hips when they had their scan. That's really to open up the femoral neck so they can get a good picture of it. People have osteoarthritis in their hips. They're not able to internally rotate and the scan isn't so good. Or the tech's in a hurry and they don't really capture the regions of interest very well and the femoral neck box doesn't overlie the right areas. So those are subtleties that you might not appreciate until perhaps you'd been in an ISCD course and learned those things. But I think anybody that's going to put up a flag and say, I'm an osteoporosis doctor, they need to be looking at scans and they need to do themselves a favor and their patients about getting good at reading them and being aware of the tremendous number of errors in the reports that would falsely, and this has been reported in at least 3 different studies about errors, one from Italy, one from Israel, and certainly ones in the United States about these errors. And it's the biggest bane of existence for the DEXA community are the errors.
Super interesting. So when I get my next DEXA report, I should look at the actual images that are included and then make sure that like the vertebra are highlighted. And if there's stuff like osteophytes that are also highlighted, then sort of question the validity of the results.
Exactly.
So what should I do if, a big osteophyte is there or some aortic calcifications?
Well, you've got a couple of choices. I mean, the good thing is the standard protocol is to do several areas. In other words, the spine and both hips as well, and even the forearm in some cases. And so your default might be, we can't really use this spine to make an assessment, so we'll just ignore it and look at the hips as well. If somebody's had bilateral hip replacements, then you're into the forearm as well. So you need to start. What drives some people crazy is, so wait a minute, if the hip is low, but the spine is normal, and the spine is low, but the hip is normal, which one do I go by? And I think it goes back to your training, I hope, in fellowship that reminded you that the spine is largely trabecular bone and the hips are mostly, depending on the area, cortical bone, and they age and accumulate and respond to steroids in a different manner. So it's perfectly reasonable that somebody might have a discordance between the hip and the spine. Sometimes it's due to artifacts and sometimes it's due to basic human physiology and the way things accrue and decline, and they respond to steroids differently. So getting comfortable with looking at different sites and making your assessment of what you think is valid and using that site to track the patient is part of all this. And there's a colleague of mine from Birmingham who came up with PAIR, P-E-A-R, when you're looking at a scan. Everybody likes to have some kind of quick remembering tool. And P is to look at the position. Just, are they square on the table? And the E is edge detection. Are the little yellow lines actually capturing the bone, or some of them too wide, too narrow? That'll throw off the reading. And the A is for artifacts. Are there artifacts, like we said, surgical calcifications, et cetera, that would be somewhat preclusive of using that? And the R is regions of interest. When that little line goes through the intervertebral bodies to designate L1, 2, 3, and 4, are they really drawn in the right place? And they're numbered. It's fairly common to have patients who have 6 lumbar vertebra, and then did the tech start from the bottom and count up, or the top and count down? And last year they counted it one way and this year the other. And then you've got apples to oranges, and somebody said, well, you're better, you're worse. And it was because the numbering was different year to year. So those kinds of things, they're not that hard to learn. And once you start making yourself look at every scan, you'll get the hang of it.
So P, position, edge detection, artifacts.
And regions of interest.
Regions of interest.
Like the vertebral bodies, is the femoral neck box placed over the femoral neck? I got called into a colleague's office last year saying this 30-year-old has terrible osteoporosis, and something about the way they positioned on the table, the femoral neck box was running over the top of the greater trochanter, and it was just a complete misunderstanding. And when I asked the person, he said, yeah, the tech told me this is the first time they've ever done a scan like that. You can ask questions like that and find out. And because very often in these big imaging centers, it's tech of the day that it gets assigned to the DEXA. And you got to remember too, radiologists have a lot of fun little tools they deal with, PET scans, MRIs. And this DEXA thing is just not big on their list. It's small potatoes. It's low revenue. They're sort of a T-score is a T-score just printed out. And so for us, it's bread and butter. It's daily life. It has to be done right, or we're making decisions. But I got to tell you, in a lot of these imaging centers, this is relegated to the lowest item on the totem pole. And so you got to be really, really careful. And particularly in the Epic world where everybody likes to cut and paste their note, and cut and pasting a DEXA report is a no-no. You need to look at the scan and look at it.
Love it. I'm going to start doing that from now on. So people might say, well, Bubba, you're right. Like T-scores, that's what I use a FRAX score.
Right.
The FRAX score is the one that's really telling me sort of the risk of osteoporosis. What do you think about the FRAX score?
That was a huge advancement. The University of Sheffield in England, the smart guys there in the bone world, came up with this in 2008 and sent it out there and said, we've got this big population of people with osteopenia. What are we supposed to do with them? Well, the FRAX was the big breakthrough. This is how we're going to be able to sort out who with osteopenia we need to worry about and who we can reassure just keep a healthy lifestyle and get your bone density checked periodically. And so that was a way to bring clinical risk factors into a quantitative situation. You could come up with a fracture risk, and you could sort out these people in that gray zone and say, yeah, your fracture risk is high enough that you would benefit from being on a medication. And so that solves some problems. And then people who start to quibble about, well, what about risk factors that aren't on FRAX? And now we have FRAX Plus, and we're soon to get FRAX 2.0. And so there are developments that are moving along that will, I think, further refine that.
Yeah, I mean, it's funny. I've seen a number of patients that, have DEXA scans. Their PCP orders DEXA scan, shows osteopenia, but with a FRAX score that would indicate that they would benefit from treatment, but they don't receive it. It seems to me that maybe some practitioners are unaware of like why the FRAX score is there, how it's calculated, like sort of what goes into it and what you should do with those numbers.
Yes, you're exactly right. And there are some imaging centers in which they'll ask the tech to fill out all those risk factors and generate a FRAX score as part of the DEXA report. And that's okay as long as the tech is pretty good at ascertaining that. You might remember that one of the questions on FRAX is, do you have rheumatoid arthritis? Well, a lot of people have arthritis. Most of the time it's osteoarthritis. And so they say, sure, and check the box. And so you get some problems with that as well, the accuracy of it. But it is something you can do on your own. You can pull it up on the website. I must say, one of the distressing concepts of the new FRAX Plus, which has even more risk factors, is you have to pay for it. FRAX Plus takes into account doses of steroids and some other features that we didn't have before. But because there was no World Health Organization or giant funding service, it's not free to add on those services. And maybe it will be in the future if there's funding. But right now, to use FRAX Plus with its extra features, it's not much, 50 cents a dollar or 50 euros or half a euro, or a dollar, something like that. But there's not really a way to charge for it. And you can't turn the patient and say, hey, can you give me $1 and I'll do your FRAX? I mean, that's ridiculous. But so I think we've got some problems with the evolution of FRAX in terms of, oh boy, we've got more risk factors to use, but how are we going to sort of bill for it and use it and make it work in clinic?
Yeah, and I guess the more complex we make it, the better accuracy it may deliver, but at a cost of, I guess you're talking about sort of financial cost, but also the more complex it is, the harder it'll be for people to fill it out correctly. And it's going to become more of a specialty tool. Yeah. Okay. And the other thing about FRAX that they've debated a lot about is, can you use it as a monitoring device? In other words, if your fracture risk this year was 22% and next year it's 18% after you've been on some other treatment or not, is that an improvement? And that was not how FRAX was designed, nor how it was tested. Dr. Bill Leslie in Manitoba has done some work with this and suggested that it might work. It might be a reasonable thing to do. And it's a big temptation because patients lock onto that kind of thing. They want to hear that whatever they're doing is working as part of this. Interesting. Okay, so let's talk about meeting that patient for the first time with a diagnosis of osteoporosis. How do you sort of frame the conversation about lifetime bone health? Because often patients may need like sequential therapy, and you sort of have to think about, how you're going to treat them if they're 50 or 60. They got plenty of years left. So how do you counsel patients about sort of the need for osteoporosis treatment, both in the short and long term?
Well, the first step is to make sure they understand what osteoporosis is. A lot of people hear osteo stuff when they come to clinic: osteoarthritis, osteoporosis, osteomalacia, osteomyelitis, all kinds of osteos out there. And they're not really sure necessarily. And they're in a rheumatology clinic, so they assume this has something to do with pain or arthritis as well. And so setting the stage by making sure they understand that osteoporosis means thin bones that break easily, and we don't want you to break a bone. Now, if they've broken a bone, you've kind of gotten over one threshold already, if they know what it is, or maybe they have a relative that broke a hip, or a parent or something that had a big change in life after a fracture, or a stooped grandmother that they remember being somewhat limited. Those kind of images help get them on the right path. So once you've established that our goal here is to talk about preventing broken bones and making sure they understand that fractures and broken bones are the same things, then you can go forward and talk about how we do that. We want to make sure your bones are strong and they stay strong. And we have tools for that. We can do bone density testing. We can look at bone turnover markers with lab tests. There's some x-rays that are sometimes helpful, T-scans, et cetera. But the long term is monitoring your bone health. Unlike, for example, cholesterol and blood pressure, I try to phrase the concept of medications for osteoporosis as on an as needed basis. And so if you get to a goal that we have in mind, we'll stop the medicine and put you on a drug holiday, depending on which medicine it is, but we'll continue to watch you. So I tell them that bone health is a lifelong monitoring exercise, but it's not a lifelong of being on medication. It's a lifelong of trying to have healthy lifestyles, exercise, fall prevention, good nutrition, those sorts of things. Those are key as components, but the idea that you always have to be on the medicine, and that is not true. And that's a big relief to a lot of patients. Oh, okay, this is not just another orange-colored bottle on the shelf that I've got to open every week or month or something and worry about side effects or cost or anything else. And so that's somewhat of a relief for a lot of patients to think about it in that term.
I like that a lot because, in patients with like rheumatoid arthritis, they often ask, how long will I need to be on this medication?
Right.
And you're like, probably a long time.
Right.
But I like your idea of framing it as like, we're trying to optimize your bone. And then if we get to the goals that we want, we could give you a holiday.
Right.
That's great. So how do you think about, so your patient has osteoporosis. You've introduced the term that this is osteoporosis. It's about thin bones, not about achy bones or anything else. And you're trying to think about treatment. In my mind, you have the anti-resorptive medications and the anabolic medications. How should rheumatologists think about choosing the right medication for the right patient?
Well, a clinician, a rheumatologist, should really think about it in terms of imminent risk. If somebody is high risk for fracture, they really ought to start on an anabolic therapy immediately. That's really their goal. You've got to do something to turn things around very, very quickly. And we've got 2 self-injection medications that are anabolic and one that's a nurse injection that has properties of both anabolic and anti-resorptive treatment. And so those are really first line for that. And ascertaining who's at high risk. Have they had a recent fracture, or is their T-score really bad? Are they going to be on steroids for a long time? What's their fracs? All those sort of things go into your calculation as part of that. And making that decision is very helpful. We now have guidelines that help back that up, because the first thing you run into is when you go to the insurance company and say, will you pay for this relatively expensive medication? And they say, why haven't they tried $10 a month bisphosphonate first? And you explain to them that the guidelines and the data shows that starting out with an anabolic treatment first works best. It works best if you use it before an anti-resorptive drug and not afterwards. And now we have the American Society of Bone and Mental Research and the Bone Health and Osteoporosis Foundation got together last year and put together goal-directed therapy where they lay this out very carefully. So you have guidelines that you can forward to the prior approval people and say, I'm following these guidelines. And even our own American College of Rheumatology guidelines tell you that. They stratify our patients according to that problem as well, the risk factors, and say, if you're bad, you really need to start with an anabolic agent and use it to its maximum. I really want the rheumatologist to think about that. It's so much easier just to write them for a generic bisphosphonate and say, try this and see what happens. And for a long time, that's kind of what people did, but we don't really have that luxury anymore. You really need to think about what the status is in terms of their risk. And we've got lots of ways to do that, including the ACR guidelines.
Got it. So what are the main factors that in your mind would place a patient at high risk?
The number one is, have they already had a fracture? And that seems pretty straightforward. No, they look around. I haven't. Well, you're actually 1.5 inches shorter than you were last year when we saw you in clinic. So everybody in our clinic gets a stadiometer height measurement. And one of the clues that you may have had a vertebral compression fracture is 1.5 inches height loss or more. And you got to remember that 60% of those are relatively asymptomatic. They don't remember an acute event. They didn't wake up one day and suddenly have acute back pain or sit in a chair too hard or something else. And so if you're relying on somebody to report to you, I've had back pain this year I've never had before, sure, that's a great reason to think about it, but you're going to miss 2/3 of the patient if that's your only tool. And so having good stadiometer measurements, and that just like they do blood pressure, not the shaky thing on the back of the scale, flop the arm, but a serious one. And the nurse makes them take their shoes off and it's been validated and graded properly, put their head right and look at it. And if you've got 1.5 inches of height loss, you're off to X-ray to get a spine evaluation. Some people have DEXA machines in their office and imaging centers that will do a vertebral fracture assessment, take pictures of the spine, particularly the vertebral bodies, to look and see if there are any evidence of compression, and it'll give you a preliminary grading on that. And that's great. And then you can bill the insurance company for it as well. Some people don't have that software on their DEXA machine, and so they end up with either a plain film or CT or something like that. But I think step one is finding out whether or not you've had a fracture. And if there's height loss involved, you better look for a vertebral compression fracture.
Got it. So if you think, if the patient comes to you with a vertebral compression fracture and a T-score of -2.6, that's high risk,
right?
You'd go anabolic.
Absolutely. And then you're starting to get into the subtleties of side effects, patient preferences, and insurance companies. It's sort of a 3-dimensional chess game about what's the patient willing to do. Are you willing to give yourself an injection every night? Or do you want the nurse to do it? And what do I think from a doctor's point of view would be your best choice as well? What side effect concerns do I have that would make one choice better than the other? And then, of course, the third dimension is what will the insurance company pay for as part of that? So juggling those 3 dimensions of patient preference, medical knowledge, and insurance companies, I think, is where we get into picking them out.
Got it. So let's talk a little bit about that. So I think the 3 medications you're talking about are teriparatide, abaloparatide, and romosozumab.
Correct.
So how do you choose among those 3? Are they, in your mind, sort of fairly equivalent, or is there a reason why you may choose some over others for certain patients, just from the clinician standpoint?
Well, strictly from the clinician standpoint, romosozumab has been looked at head to head with the parathyroid hormone related treatments, and it's a better drug. It gives you more bang for your buck in a shorter amount of time. In a year, you get a really big boost in bone density and a big reduction in fracture risk, which is what we're looking for. So it's faster and better in some ways. In my region of the country, Medicare Part B pays for it, which is nice. It's one of those covered drugs as part of it. So that makes it very handy for a lot of people. And as I mentioned to you, some of the people that we get sent are pending spine surgery or hip replacement surgery, and their surgeon wants their bone optimized. This will do it a lot faster than, for example, the self-injection. On the other hand, that means you've got a trip to the doctor's office every month to do that. So, but that gets into more of the practical aspects of the patient. But one other thing to think about is if you start off with a parathyroid related drug and you don't get the response you get, sometimes switching over to romosozumab may give you an extra boost because there are 2 different mechanisms involved. We don't really see the opposite doing very well. In other words, if romosozumab didn't do well for you, it's not very common that we would see that one of the parathyroid analogs would actually pick up the pace after that as well. So that sequence seems to be, and there's more work to be done in that area. I don't want to say that I'm the last word on it by any means, but it seems to be that if you're going to start out with the self-injection medication, which frees people up from not having to come to the doctor every month, you have the option of switching over to the romosozumab later on if you don't get the results you want. You don't quite get the opposite choice that well.
And the other thing you mentioned was about sort of side effects. So how do you how do you view these three medications in light of a patient's comorbidities?
Well, as you may remember, when the teriparatide came out, which is almost 20 years ago now, there was this concern about osteosarcoma that was seen in the laboratory animals. And so one of the first things the FDA did was say, don't give this to anybody who might be at risk for osteosarcoma. For example, those who've had radiation treatments, young folks who haven't closed their epiphyses, people who have Paget's disease. And so that group has been put aside, and radiation is pretty common. A lot of people have had breast cancer, prostate cancer. In the old days, people were getting radiation for acne, all kinds of things. So that puts some people at a little bit of risk and concern. But as the 20 years have moved on, we really haven't seen osteosarcoma as a big problem from these drugs. And to be fair, rats have a different physiology of bone than humans do. And so there are some differences. I don't mean we're cavalier, but I have certainly talked to patients and given it to them with radiation. And one group we are nervous about are people who already have metastatic cancer to bone. I don't think we feel comfortable about giving them a growth agent and they already have mets to their bone. So those folks make us a little bit nervous and as part of that. So that's one of the factors that comes up a lot about, have you had radiation before? And it doesn't mean you can't have it, but it does mean you have to have a pretty detailed discussion with the patient.
Great.
Romosozumab, on the other hand, carries with it the cardiovascular story. And that's an interesting story that continues to get debated. This idea that in one of the big clinical trials, there was a difference in strokes and heart attacks in the people on alendronate versus those that are on romosozumab. The difference wasn't much, but to the FDA's credit, they're very sensitive to the small differences and said, okay, what are we going to do about this? And after many advisory panels and discussion, it wasn't anything obvious. It wasn't as though romosozumab was causing blood pressure to go up or cholesterol to get out of balance. There's a theoretical idea that sclerotin's on vascular surfaces, and maybe by blocking it, you may be increasing the risk of thrombotic events or something like that. It's still not quite worked out. So they ended up putting in the label, don't give this to somebody who's had a heart attack or stroke in the last year or somebody who you consider at high risk for those events. So that's left a lot of gray zone. And some doctors have interpreted this, well, I need to put this person through a full cardiac workup, stress tests, calcium scoring, the whole 9 yards. And others, hey, you haven't had a heart attack or stroke, your cholesterol's been well controlled, go for it. But it lurks in the background, and somebody says, oh, I have atrial fibrillation, or my grandmother had heart failure. And so it's made for a difficult situation. But after, 6 years on the market now, we are not seeing patients falling out with strokes and heart attacks. But for the most part, we try to avoid giving it to people with those risks. So those two big camps of side effects are what we deal with in the clinic, is talking to patients, trying to put them in context, and making sure that we're comfortable, the patient's comfortable about all that sort of thing.
Got it. And then, after given, these three anabolic agents are given for limited periods of time. How do you sort of discuss that with the patient? Because it's often difficult to understand. It's like, wait, you're giving me one drug and then I have to do another drug. I thought we're not going to use bisphosphonates. So how do you explain that to patients? And what's your management style after patient has finished those anabolic treatments?
I have a handout that I give every patient in clinic that has a graph of the normal course of bone density over the lifetime that Riggs and Melton published 35, 40 years ago. And I try to show them where they are on that graph and explain T-scores based on that as well. And I explain to them that these medicines are trying to drive your bone density up. And if you do nothing, the natural course of events is for it to fall right back off again. And so we can give you a medicine like bisphosphonate, intravenous alendronate, for example, that will try to maintain the gains that you've had. And you may not need to take it very often. In other words, a couple of years of teriparatide and then a dose of this, and you may be good for another couple of years without anything else. And we'll just keep an eye on your bone density. And that sort of predetermined treatment plan appeals to people. So I know I need to get this part and then we'll be off for a while, and you'll just keep an eye on things and tell me if we need to go again. And that's how we tend to present it, as a build up and then try to preserve what you've built and then retreat if you need it. I would have to remind my colleagues that back in November of 2020, the FDA took the lid off the 2-year restriction on teriparatide and said there are patients who benefit from another course of it or benefit from prolonged use of it. We are not going to restrict it to 2 years. And if you need it for longer, you need it for longer. And that's been very helpful in discussing with the insurance companies about why we need to do another course of it or prolong the course if the patient's getting good benefit.
Got it. So the typical treatment for the PTH analogs is 2 years of treatment and then switching to a bisphosphonate. Whereas I think Romo is just 1 year of treatment and then switching to a bisphosphonate.
Yes. Or you could use denosumab if you want. That brings up a lot of other issues, though, for denosumab.
Okay. So let's talk about that. So you mentioned for high-risk patients, you're going to go for the anabolic agents. Let's talk about sort of the not high-risk patients with a T-score of minus 2.6, have not had a fracture. Their FRAX score, well, I guess they have osteoporosis anyways. So how do you think about choosing among the, I guess, denosumab and bisphosphonates in their treatment?
We talk a lot about goals of treatment. And in those folks, and again, that's the ASBMR guidelines is talking about. Those folks were trying to get your T-score down a bit, assuming it was done correctly and it's a valid T-score and so forth. And we've got proper tools to monitor it. And so our goal is to not only prevent you from getting a fracture, but treat you. You have a lot more flexibility about on and off with bisphosphonates than you do denosumab. Once you've had a couple of doses of denosumab, you're now getting into the world of the risk of rebound bone loss when you stop it suddenly. You probably get the first 2 doses of it as a freebie, but after that, you start to run the risk of this rapid bone loss and multiple vertebral fractures when you stop it as well. So I'm a little bit cautious about using denosumab in the low-risk patient, the one that has maybe a T-score of minus 2.6, you said, but doesn't really have a lot of risk factors, and particularly if they're young. The nice thing about denosumab is there's data to use it for at least 10 years if you need it, and there's no reason you have to stop it if they continue to need it or are doing well with it. But if you're going to start somebody with denosumab at age 55, boy, that's a long time to stay on a drug. So I tend not to do that in that group. There's a little niche that was cut out that you probably heard a lot of people talk about, that denosumab is very kidney friendly. It's not hard on your kidneys. And perhaps bisphosphonates, if given incorrectly, or if you have CKD, it's maybe not as good. I'm not sure all those are quite accurate, but people tend to remember little snippets so they can make clinical decisions and move on. And the problem with denosumab in really bad CKD, 3B and 4 and 5, is that you run the risk of hypocalcemia. So you have to monitor these patients every week and then every month and then every 6 months and so forth as well. But I think of denosumab as maybe a little older in life, maybe with some kidney problems, and maybe because they haven't tolerated bisphosphonates. It seems to be a more potent drug for reducing fracture risk. And so if you're really trying to achieve something that you might not achieve with bisphosphonates, you'll probably get there faster with denosumab.
Interesting. Okay. So maybe reserved for, like you said, older patients who have CKD. How about you? ESRD. I recently had a consult patient with osteoporosis and on dialysis. I guess those patients are very complex.
They are complex, and we get a ton of them as well in our clinic. And as one of the endocrinologists did a consult on, one of them said, there are no FDA drugs approved for you. I'm sorry. And I thought, whoa, that's a nice thing to say, keeps you out of trouble, but it's not really going to help the patient. And I think the issue with these ESRD dialysis patients is you've got to dig deeper into their whole metabolic bone profile, because some of them have adynamic bone. They're not making any bone. And so they would definitely benefit from an anabolic agent. Others are in a very high turnover state and they're losing bone. And some of them have, completely unrelated to bisphosphonate or anabolic, they have other metabolic problems with phosphorus and magnesium and so forth. And so once upon a time, KDIGO guidelines said, before you treat these people, you need to do a tetracycline labeled bone biopsy on all of them.
Wow.
And I'm at a medical center that has that facility. And so we used to do that, and we even published our results, but it's a big deal. And there are only a few pathologists in the country that know how to read those. They have to be processed in a certain way. So that's not really practical. So what we defaulted to, and Tom Nicholas, who's now at WashU, has done a lot of nice work with this, is using bone turnover markers in the ESRD patients to try to get a glimpse of what's going on metabolically. Things like specific alkaline phosphatase, parathyroid hormone levels, and procollagen 1 N-terminal peptide, P1NP, which fortunately is not filtered by the kidney. So it's a valid turnover marker even in ESRD, which is not true for CTLO peptide, for example. And so using bone turnover markers as an indirect way of looking at whether a patient's a high turnover or low turnover and trying to make a decision whether they would benefit from an anabolic drug or an anti-resorptive drug is kind of the tools that we're using now. And this is all assuming that you can stabilize their vitamin D, their calcium. And we work with the nephrologist to try to get calcium baths in an optimal range as well. PTH levels and vitamin D. So it becomes a collaborative effort with the nephrologist in many, many cases.
Got it. What about bone turnover markers in patients who don't have ESRD? Do you ever think about, do you get those routinely in patients with osteoporosis?
I do. I'm a bone marker guy. I like them. I find them helpful. There are a lot of boneheads across the country that don't use them because they have a broad range of normal and what you call precision error, least significant change is pretty wide as well. And some of them, like CTLO peptide, are affected by the time of the day you check them and whether the patient's fasting or fed. And as we just said, renal function is part of it. So there's some variability. So we typically get 3. We get bone-specific alkaline phosphatase, P1NP, and CTLO peptide. And I'm looking for trends that all of them sort of fit in that pattern. It's particularly reassuring to patients who are on a medication and they're not due to get another bone density. Insurance won't pay for one for another 2 years. And they're saying, how do I know that whatever I'm doing is actually working? And I'm paying this copay every month or whatever. And how do I know we're getting anywhere? So the bone turnover markers can sometimes be helpful. If you're on an anabolic drug, the P1NP might shoot up quite high. And if you're on an anti-resorptive drug, it might drop down and you might have a goal below 30 as a way of saying, it's working. We're getting where we want to be. I feel good about this. And so I use those in that way. Other colleagues are not so confident with those, but I think they can be helpful. And for most part, the insurance companies will pay for them now.
Great. And, the other question we often face let's say you choose, the patient does not have severe osteoporosis, you want to do a bisphosphonate, then choosing oral versus IV. How do you frame those discussions with patients and what are your recommendations?
Well, a patient who's never been treated and has never taken anything and has been digging around the internet very often has tremendous fear about, or that's why they end up in my clinic because somebody else said, I don't know what to tell you, but so go see Bobo. And so we'll talk about that. And sometimes the oral agent appeals to them because they feel like they're in more control. It's just once a week. If they don't like it, they can stop it. Ironically, alendronate has a 10.5-year half-life in your bone. So it's when you stop it, it really doesn't just go away as part of that. But so some people feel like they have control. But there's a remarkable amount of GI upset with these drugs. And some people it's fairly benign and others it's more of a problem. You have to take it on an empty stomach. You have to wait a half an hour. And if you have your routine in the morning for your coffee or tea or whatever you like to do, that sometimes interrupts these things. And quite frankly, when they did head-to-head studies with the IV versus the tablets, the IV wins. You get a whole year's of adherence. And so there's no question about it. And quite frankly, these people do better. And Ken Lyles at Duke actually published some information that the FDA acknowledges the IV actually seems to improve lifespan. These people seem to get less of the long-term diseases that kill us. And so the IV, for my money, wins the prize. And it's one dose, you're done for the year and so forth. There is this flu-like illness that maybe 20% of the people get. And for some people, it's a real whopper. And it's not an allergic reaction, but it really knocks some people down. So you're really incumbent upon you to make sure they understand that and so that everybody's prepared for it and not get the emergency phone call the next day saying, I feel terrible. I must have had an allergic reaction. Why didn't you tell me this could happen? And so forth. I'm going to the ER as well. But for me, the IV has a better track record for benefit and obviously more adherence. You can often get away with 3 annual doses and then take a pretty good long drug holiday from it.
Yeah, I was going to ask about denosumab. You sort of continue indefinitely. The anabolic agents in general, they sort of have, you treat it for a year or two. Bisphosphonates. So zoledronic acid, you use just 3 years. And then how do you monitor to make sure that it's working? And how do you do the same thing for oral alendronate?
Well, going back to the original registration trials, most of the benefit from the IV occurred in the first 3 years. There were studies that took it on out to 9 years, and some folks got a little bit more, and you can quibble about some things and who needs to stay on it that long. But for the most part, 3 years is a good target. And then you've got your bone turnover markers to watch. They're not always reliable. And if they're suppressed and they start to come up again, it would suggest the drug is wearing off. 2 years was a time that was looked at in terms of maintaining a lower fracture risk. And after 2 years off the drug, the fracture risk started to come back up again. Bone density testing, again, can be helpful if somebody's bone density looks good. And then after a couple of years off the drug, it starts to trend in the wrong direction. Those sorts of tools we use to make a decision whether you need to go back on a drug. Some people do quite well and may go more than 2 years before needing another drug. The oral agents probably get their maximum benefit in 4 to 5 years, some of them 3. And so I'm reluctant to push that. And also the threshold for starting to see some of the rare side effects, atypical femur fractures that have been associated, they tend to come on after 5 years of continuous treatment. So that's kind of a soft stop for a lot of people. Is you've probably gotten all you're going to get at it, and you're starting to cross into a zone of possible rare side effects. So why don't we take a holiday and let you come back down to a low risk for those side effects and also still get some benefit from the drug that carry you through that holiday.
Yeah. Osteonecrosis of the jaw and these atypical femur fractures that you mentioned, I think keep a lot of patients away from these drugs.
Yes.
How do you counsel them? How do you talk to them about these risks?
This is one of the reasons my clinic is always running long.
It's these discussions, right?
Right. They want to know about all this. They've seen something on the internet or had a neighbor or friend or whatever that something happened, or a dentist that told them, if you ever take these drugs, you can't be my patient anymore. I can't work on your teeth anymore. So we got a lot of those kinds of people in here. So I try to go over them with exactly what's going on and why this is a concern. And this issue with the teeth tends to be with poor oral hygiene, smoking, etc., not regular checkups, and some sort of dental procedure that involves an invasive gum procedure, either dental extraction or perhaps an implant. It's not cleaning and caps and fillings, and really not even root canals that trigger it, but something that interrupts the gum so that it's no longer adherent to the jawbone, and that bone then becomes exposed, and the gum doesn't grow back over it very easily after bisphosphonates have been around, and you get this possibility of an infection with actinomyces, which can really damage the bone. So most modern trained oral surgeons now, when they pull a tooth and somebody's been on bisphosphonates, will give them chlorhexidine mouthwash, do primary closure to make sure the gums, and maybe even a day or two of amoxicillin. But what I think is most important, they'll see them back in a week and say, make sure it's all healed, and not just wave at them, call me if you have a problem, sort of thing. And the American Academy of Oral Surgeons put out some guidelines for patients that were on denosumab as well, about when to pull teeth and how to monitor them. And the American Dental Association, they've all said stopping these drugs is not something dentists should be encouraging because of the possibility of fractures, and they don't want to be responsible for that as well. But working with the bone doctor and the dentist together to come up with a plan is usually what's in. Good oral hygiene. Get your teeth cleaned. Go to the hygienist twice a year and get your teeth cleaned.
Great. And do you talk to them about numbers, like how likely it is that they encounter one of these rare side effects versus the benefit from these drugs?
Yes. My colleague, Mike Lewicki in New Mexico, did a great service to the field about 15 years ago, publishing a nice little PowerPoint slide that I've shown to patients that shows the risk of a fracture compared to the risk of osteonecrosis of the jaw and compared to getting struck by lightning. And it's a beautiful, and osteonecrosis of the jaw, the risk is down there in the range of getting struck by lightning, which is fairly uncommon. It's not zero, but it's way less than having a hip fracture or a vertebral compression fracture. So trying to put it in perspective for them. Now, if you have it happen to you, then it feels like you got struck by lightning and it's bad luck. But again, counseling them on dental care and working with their dentist if there is a concern is a big part of it.
Yeah. And anything about these atypical femur fractures? What do you tell patients? Is there anything they can do?
Yeah, I tell patients a lot of it has to do with length of treatment. So that's why we put the brakes on in 3 to 5 years. And also, is Rick Dell did a big study with the Kaiser Permanente database in California and showed that there's a real step off with this time frame. And he also found out that there were risk factors that we hadn't previously appreciated, particularly if you have an Asian background, you have parents or grandparents that were Chinese, Korean, or Japanese, there seems to be a genetic tendency. Also, if you have congenital slight bowing of your legs, the bowing of the leg tends to put stress on the outer cortex, which is where you see these atypical femur fractures just below the lesser trochanter. And so having a congenital bowed leg puts you at risk for this situation. And also, back to the rheumatologist, chronic use of steroids. So those 3 risk factors, plus the use of the bisphosphonate for a long time, those things I bring into focus and say, you can see that you are probably not at high risk, and we are going to stop the drug in about 3 years, and we will take x-rays of your femurs the minute you tell me you have any thigh pain, and you should let me know immediately, and we'll look for that beaking and the dreaded black line that can pick this up.
Great. And Bobo, last question. In looking forward, anything you're excited about or anything you feel like the field needs to learn about management of patients with osteoporosis?
2 things come to mind. One of them is the avalanche of the surgeons wanting their patients optimized before surgery. Medicare just last month put out something called the TEAMS guideline, meaning that certain institutions were designated to be part of this prepaid package of hip and knee replacements and spine surgery. And before the patients could undergo it, they have to have bone optimization. In other words, a DEXA scan, a meeting with a bone person to make sure that all their metabolic parameters are in good shape beforehand, because Medicare is at least recognizing that that's going to have a huge impact on the success of whatever surgery is planned, and therefore less cost on the other end. So that means there's going to be a huge demand for people to see these patients. And as we were saying earlier, people got to get themselves up to speed for this. There are a lot of resources for how to do that. And the second thing that's going to maybe cause an avalanche is this idea of using CT scans in a way that predicts who's going to have a fracture. Looking at Hounsfield units in lumbar 1 is a way of getting a gauge on the quality and strength of the bone. And Hounsfield units of less than 100 and one of those little ovals that you drop on L1 can be at high risk. So there are health companies or large medical organizations that can run through with AI their whole set of CT scans for the last 5 years of the spine and pick out patients that have not necessarily been diagnosed with osteoporosis that now are considered at risk. It's called opportunistic CT scans. And this could generate a huge number of patients that are not aware of this. And again, who's going to take care of them? And frustratingly, who ordered this in the first place? And did somebody in the healthcare organization talk to anybody about how we're going to see these patients? How are you going to tell them about it, and so forth? So I see those as 2 big projects that are looming on the horizon that are going to require a lot of clinician input as part of this. Maybe good for the patients, but going to need a lot of clinician input.
Bobo, this has been an awesome conversation. You're so knowledgeable and are able to really put things into perspective and that patients can understand. And this has been really enlightening for me. I can't wait to get back to clinic today to look at some DEXA scans from my patients and see if I could figure out if there's anything wrong with them. But it's been a pleasure chatting with you today.
Well, I'm glad I ran into the ACR. This has been great. I appreciate this.
There are 2 big takeaways I'm holding on to from this. The first is humility. Don't let a single printed T-score become the whole story. Try to look at the scan. Use a structured checklist to see if you agree with the report, because the downstream consequences of getting it wrong are enormous. The second is that osteoporosis treatment is really treatment planning. Not just what drug, but what sequence, what goal, and what exit. Dr. Tanner describes a model patients can actually understand. That is, to build bone, preserve what you built, and then retreat if you need to. And in higher risk patients, the conversation shifts from maintenance to urgency. You have to treat fracture risk up front, often with an anabolic first approach, and then use the guidelines and data to support your decision. Until next time, keep interpreting those DEXA scans. And of course, stay healthy.
This podcast was edited by Resonate Recordings.